Good afternoon, everyone. Isn't this great, being in person? This is the first conference I've attended, and I've really missed it. And I'm glad to be a part of this as my first conference in person. My name is Christine Frank, and I'm a highway safety specialist with the National Highway Traffic Safety Administration. I'd first like to thank Darren, Responsibility.org, GHSA, and AAA for allowing NHTSA to be a part of this very important discussion. I'm sharing the stage with another Christine. We're calling ourselves Christine Squared. Dr. Christine Moore was the chief toxicologist at Rapid Diagnostic Division of Abbott. She recently retired. Congratulations on your retirement. She is now the president of 9 Delta Analytical, which is a laboratory for academic research groups, nonprofits, and government agencies. So I'm honored to be sharing the stage with her today, and she'll be talking a lot about the research and some of the topics that have already been discussed in the way of oral fluids. So when Darren first asked me to come speak and moderate this session, I thought to myself, and Darren mentioned this earlier, this isn't a new problem, right? Law enforcement, certainly the law enforcement entities in this room know that this is a problem that we've been dealing with for decades. I remember early on in my police career where I stopped an individual for swerving, unsafe lane change, contacted the driver, slurred speech, odor of alcohol, performed horribly on field sobriety tests. I arrested her, took her back to the substation. She blew into the intoxilizer and was a .02. I said, I'm not very good at my job, am I? I thought for certain she was a .16, just by her behaviors and by her HGN, her horizontal gaze nystagmus. And I called for a drug recognition expert. You've heard that term already this morning. And subsequently, after evaluation was completed, it was determined that the individual was on Valium as well as alcohol. And for those of you who don't know, Valium is a central nervous system depressant, just like alcohol is, and creating an additive effect. And so 1 + 1 doesn't always equal 2, it could equal 3, 4, and 5. And so that's why we're here. We're talking about this multi-substance abuse, which is what we're seeing and have been seeing. I'll get to the unique issues of today in just a minute. Fast forward to later in my career when I was a DEARY and a DEARY instructor, dispatch received a phone call of a Domino's pizza driver who went out on a delivery and never came back. Shortly thereafter, dispatch called and said a Domino's pizza driver had been involved in a crash. And after the arresting officer took that subject back to the substation, I was called to do a drug recognition evaluation on them. And here's what they were under the influence of. So you'll see Soma, it's a muscle relaxer. There's narcotic analgesics on board, morphine, tetrahydrocannabinol, THC, some other drugs. I mean, just think about that. This person was delivering your pizza. Quite frankly, my discussion with him, he didn't really think it was that big of a deal because he was getting off harder drugs. So, all the more reason we need to be doing what we're doing here today. Some unique challenges we have today that we didn't have a decade ago when I did this evaluation are some of the things Darren mentioned earlier. Use and abuse of opioids like we didn't have back then. Legalization, decriminalization of marijuana across the country, which lends to a cavalier attitude of driving under the influence of marijuana. And new synthetic substances occurring at alarming rates. So because I'm from NHTSA, we love statistics and data, and so I've got to briefly talk a little bit about them. What we're seeing today, the early estimates are showing, even though there was a decline in vehicle miles traveled, so that's the VMT, there was a rise in traffic fatalities. So VMT was down over 13%, traffic fatalities were up 7%. This is during COVID. That's why VMT was down, right? Less people on the roads. You would think we had less risky driving behavior, or we're seeing less results of it. But really what we're seeing is more risky driving behavior. And it was mentioned earlier today that impaired driving is one of those risky driving behaviors, along with speeding and no seatbelt use. That's on the increase. 2021 estimates show statistical progression. 8,730 people died, an increase of 10.5%. So, and you'll see some other statistics up there about the regions. Those 10 regions are all NHTSA regions, and there's an increase everywhere across the country. It's not just a regional problem. Another good report that just came out from the Insurance Institute of Highway Safety, showing crash rates after marijuana legalization. They did increase, the numbers increased. It's good to remember that the marijuana of today isn't the marijuana of, I'll date myself, my decade, 4% approximately when I was in high school, compared to at least upwards of 14% now. And that's excluding dabbing and wax. So it's we have much more unique challenges today than we had a decade ago. So at NHTSA, we have a DRE data system where we compile all of the evaluations that are conducted by law enforcement officers that are DREs around the country. And what you're seeing here are the evaluations that have polycategory use. So to distinguish the two, we're talking here today about polysubstance, right? Multiple substance use. The example I gave you earlier about Valium and alcohol, that's polysubstance, that's multi-substance. What you're seeing on the screen here is a graph depicting polycategory. So drug recognition experts determine one of 7 drug categories or more that someone's under the influence of. So this number, even though it's 34%, and that's a lot, multiple substance abuse is much higher than that, because they could have been on 12 drugs and only 2 categories. So put that in perspective when you're looking at these statistics. So I stumbled across this quote that I thought was really good for what we're talking about here today. The first part is getting everyone together, and I can't thank responsibility.org and Darren and NACID enough for starting these conversations in a more organized manner. So Einstein said, we cannot solve problems with the same kind of thinking that created them. And that's what we're here today and tomorrow to do. So a multi-substance problem is going to take a multi-substance approach. No one approach is going to make a significant decrease, and no one profession will make a significant impact. It's going to take educating the public. It's going to take educating law enforcement, educating politicians, all creating a change in attitude. Think about how long it took to stigmatize drunk driving. We're in those throes of trying to stigmatize drugged driving right now. It's going to take an increase in law enforcement training, better drug detection tools, and more efficient processes, like you'll hear about later today, including e-warrants and law enforcement phlebotomy, and a focus on intervention prior. Part of the solution starts with research, which is why we have the expert on the panel here, Dr. Christine Moore, who will be talking a little bit more about the insights of where we are and where we need to be. Dr. Moore?
Thank you, Christine, for that very nice introduction. Where's the thing to change it?
I stole it.
You can just look at this for 20 minutes now.
You know what? Let me get
very
this
interesting. I also would like to thank responsibility.org, especially Darren and Andy and Karen and Christiane for helping me put this presentation together and for inviting me today. This is a sort of a general overview as to what we're going to be going into more depth about as the rest of today go on. I'm just going to do this on.
Yeah.
Yes, sorry. I'm going to go over just a couple of reports, the salient points of those. just so you don't have to actually read them yourselves, but you can if you want to. But this is just some minor points that are interesting. Oh, and one thing I had to mention that Darren told me was I was only allowed 7 slides. So all that does for future reference is make you make the font size smaller. So, just so you know. So in 2018, the CDC had a fact sheet that people admitted, 12.7 million people admitted to driving while under the influence of marijuana or other illicit drugs, admitted to it. So God knows how many didn't admit to it. So that's a little bit scary. And that's the reference to it there. In 2019, this is a national survey on drug use and health. While not specifically directed at driving, what it does do is give us some information about trends in drug use in the country. It's mostly about substance use disorder and mental health, those kinds of things. And it was finished pre-COVID, so this is before COVID hit. And the thing to note, as then may relate to driving, is that marijuana use and disorders were increasing across the board, especially in adolescents. Opioid use actually went down, which was very interesting also. But the important thing for this meeting, polysubstance abuse, is now the normal thing. Nobody uses one drug anymore, unless it's alcohol. But if you're doing drugs, you're probably doing alcohol plus drugs. This was a report from the European Union as we're talking about driving. While that substance abuse survey wasn't specifically about driving, this one sort of put together the chances of you being killed or seriously injured in a collision, depending on which drugs you took. So for cannabis or illicit opiates, it was about 1 to 3 times more chance of getting killed there than if you didn't take them. And that's consistent with what was seen in other reports for cannabis. It's about 1 to 2 times more likely that you may cause an issue. But cocaine was worse, at 2 to 10 times a greater risk. But don't do methamphetamine and drive, please. Look at that number. You're going to kill yourself or someone else. Please don't ever do that. 5 to 30 times more likely to be killed. So that's a bad one. And these are alone. When we talk about polysubstance use, that's way worse. So our friends at NHTSA did a very interesting project, and they put out this interim report, which is ongoing. The project is ongoing. There should be an update to this report sometime soon, I hope. This was published last October, and what it was they collected blood from trauma centers, from roadway users that had been taken, obviously, to the hospital. And it wasn't all drivers, it was predominantly drivers that had been fatally or seriously injured, but there were some pedestrians, some bicyclists, motorcyclists, things like that. And they collected these bloods in Jacksonville and Miami in Florida, in Charlotte, North Carolina, in Baltimore, Maryland, and in Worcester, Massachusetts. So they had 5 sites. They've since added Iowa City, I think, and Sacramento. So in the next report, we'll have additional data from those 2 sites. And what they found in drug prevalence in these folks, that they were positive for at least 1 active drug, half of them before the pandemic began. So the green bars that you're seeing are pre-pandemic. So this was January, February, March of 2020. The orange bar, that is the first stage of the pandemic. So that's April, May, June of 2020. And the blue bar is July, August, September. So then the report came out in October. So during the pandemic, that number that who had active drug in their system jumped from 50% to 64%. That's really scary. 2/3 of people driving around in the pandemic that were injured had an active drug on board. And by active, they mean THC, native THC, parent THC, not the metabolites. This was actually active marijuana. And you can see on the graph there that, actually you can't see on the graph, but the THC was actually more prevalent among drivers than was the alcohol, which was also a little bit scary. But opioid use almost doubled. And if you note pre-pandemic, the alcohol and cannabinoids were about the same. But in that first stage of the pandemic, marijuana use shot way up. I have no explanation. I'm not an epidemiologist, but that's way higher. But opioid use almost doubled. Now, I'd like someone to explain to me why antidepressant use went down. I would have thought you'd be more depressed in COVID, but that's true. They couldn't get a prescription. That's a good point. But anyway, that was the overall interim report. And I know there are probably some folks from NHTSA here, of course, Christine, but also other people, and certainly virtually, that may have more information on this report. So just to switch gears a little bit to laboratories and what are they seeing in their casework. So they get these samples in the door for analysis. And in 2016, there was a survey done of what labs were seeing, what top 10 drugs did they see in their samples. And you can read them there, of course. Marijuana and its metabolites is always the highest one, most prevalent. But 4 of those top 10 are benzodiazepines. So 40% are in that class of things which will send you to sleep, and you probably shouldn't be driving if you've taken a lot of them. The amphetamine and codeine are in red because on the top 20 list, which went to top 15 drugs, those had disappeared and been replaced by probably methamphetamine instead of amphetamine, and yet another benzo in temazepam, and fentanyl, of course. Everyone knows we had a big fentanyl epidemic in those intervening years. This was a survey that was carried out by the Center for Forensic Science Research and Education. And they did, as I said, this was an update. And the survey questions covered lab testing for these drugs in blood and in urine. And they asked about the protocols for further testing of blood samples. Specifically, a lot of places, if you get an alcohol above 0.08, you don't do any more testing because they're already, you have that. What's the point in testing for drugs? It costs more, why bother? The person's already impaired. So a lot of that's financial. There's lots of arguments on both sides as to whether that's a good idea. And one of the best experts on that is Jennifer Harmon, who's sitting right over there, who's done all kinds of work on why you should be testing for drugs in blood, right? And not just alcohol. But you can understand that jurisdictions don't want to spend that money if they don't have to, especially if there are no added penalties for having drugs. You've already got them on alcohol. So it's a discussion that we should certainly have. But this survey asked the labs about that also. And overall, those laboratories were moving towards compliance with these recommendations from the National Safety Council, which were about which classes of drugs were considered tier 1 or tier 2, so which were more important than others, and at what concentration should you be testing, at what cutoff. Those were the recommendations. So overall, the labs were moving towards that, but they all reported an increased workload from the 2016 to the 2020 survey. There was a shift from gas chromatography to liquid chromatography technology. That's because the GC technology, while great, is a little more labor intensive. So you can streamline a little better with the LC technology. And scaringly, really scary, 35% of labs were reporting unconfirmed screening results. So this is just usually an immunoassay screen in the laboratory where it's a presumptive positive. It might be one of these drugs. Now, it's pretty good. It's likely to be one of those things, but you're not 100% certain unless you do a confirmation. So 35% of labs that go with that, maybe again for finances, maybe their jurisdiction doesn't care, this is good enough, maybe the person pled guilty, I don't know the reasons, but that was a lot. The challenges to some of the recommendations were that they believed that their methods were already fit for purpose, so why should I bother changing it? Because some person out there tells me I should. It's good enough. And why waste resources achieving these recommendations? So reasons for the recommendations, you would like to have each state testing at the same level. You could be negative in California and positive in Nevada if you drive across to Vegas, maybe. So standardization is good in a lot of cases, not every case, because then you lose flexibility. Again, a great discussion to have. For those of you who are not toxicologists, an ELISA plate is an immunoassay type where it looks for specific classes of drugs. You can't get all the benzodiazepines that you would like in one plate. So you have to then add on more plates if you want to get more of these things which are being recommended. So labs kind of push back on that too. Staffing, training, time, money, things we've heard all the time with the challenges for lab work, lab space. They don't agree with the recommendations. And worryingly for me, because I'm a big advocate for oral fluid testing, they say that's not really a priority to implement at this time. Most labs do blood for DUID and some do urine also, which is not so great. But oral fluid analysis was not a priority at this specific time. So, to summarize on my 7th slide, Darren, just saying, traffic accidents and fatalities are increasing, but we don't know for sure that that's definitively drug-related, but we do know that drug use went way up in the pandemic. So, two things going along with each other. 64% of these folks that were killed or seriously injured had an active drug in their blood. THC was more prevalent than alcohol, and a lot of these folks had polysubstance use confirmed. The challenges in 2020, only 12% of those labs said that they met or exceeded these recommendations. But in good news, 44% were close. They're working on it, so we're getting there. There were some differences in identifying which drugs should or should not be tested for, and I think that's a lot to do with geography. You know, you may have pockets of specific drugs in different areas of the country, so that's hard to standardize. It's hard to standardize that. There's definitely some pushback on adopting these laboratory standards, and oral fluid is not a priority for implementing in the labs at this time. There's a great deal of misleading information in the literature on oral fluid, and I'm going to talk about that tomorrow. I have a specific presentation on oral fluid itself, advantages, disadvantages, so I'll go into that a little bit more tomorrow. But some of that has been misleading, and I think that's held back oral fluid technology and implementation a little more than it should have. So, thank you.
So let's have a chat. So I'll kick off the Q&A. You talked about some lab challenges, and I'm curious as to what your thoughts are on considerations labs should take when they're thinking about standardizing, or they're thinking about what should be in their screening panel, their initial screening panel.
So I think that the point of the recommendations, and there's some folks here that were on the committee that put those recommendations together, and feel free to chime in over there, is that exactly as I said, if you're moving between states, you don't really want different cutoffs or different standards of testing. But the difficulty is the geographical variation, because sometimes you'll have a lot of methamphetamine in Anaheim. You know, Disneyland is the happiest place on earth, but there's all kinds of meth down there. You may not have as much of that in, let's say, New Hampshire, I don't know. So that's the difficulty with trying to standardize. In such a big country, it's a lot easier than the small countries, but this is like 50 countries all trying to do the same thing. So it's a challenge.
So standardization seems, for all intents and purposes, impossible, but protocols are standardized.
I don't think it's impossible. It's impossible to get toxicologists to all buy into the same cutoff. There was a conference I was at once, and they said, you can't get two toxicologists to use the same method. It's like asking them to use the same toothbrush. So that was it. They all like their own. It kind of makes sense. That's somebody said it to me, and I liked it, so go ahead.
Anyone in the room have questions? Somebody does. Yes, up front.
And I definitely don't need a microphone. So I'm a executive director of a nonprofit, a community coalition. So we write grants trying to improve our communities. And when you were talking about the data on the increase in fatalities, we need the data saying whether it's the drugs and alcohol that's increasing, because, and I'm from rural, of Frontier, Nevada, so I cover, and I know Karen, and I cover 27.8% of the state with 2.2% of the population in it. And so we drive great distances. We have Interstate 80 and 15 and all the good ones. And so they're saying, not the general population is saying it was the speed that increased our fatalities because they were driving faster and greater distances. So how do we get we sometimes on our level don't get the data until it's 4 years old.
Right.
And so then, by then it's too late for us to put our prevention efforts into what's really happening. Because like you were saying with methamphetamine, by the time they were admitting the meth use, opioids were more of an issue. So how can we, on a lower level, get the data so that we can start working on things in a more timely manner?
Well, were they driving faster because they were on meth?
I was just going to say that, yes.
Because we have 80 miles per hour as our speed limit through a lot of our states. So we do have higher, see, I can do the same thing.
That's all right.
So we have higher speed limits than like New Jersey or somewhere.
Yeah, I didn't mean to trivialize your question at all.
I smiled.
It's, I think it's an issue with reports. They just take such a long time to come out, and the reporting from the states is different. Not all the states report the same kind of data. As we've said, some is just alcohol. They don't even report the drugs. So, yeah, so it's hard to make sure that's all standardized. And you being from NHTSA, you can speak to.
Yeah, so to add on to the challenge that Dr. Moore is talking about, another challenge is for the majority of states, I won't say all, but for the majority of states, there's no distinguishment between driving under the influence of drugs versus alcohol. And so when you're compiling data from states, you're seeing, DWI or DUI or whatever it's called in that state. And so it's hard to distinguish unless you have someone really taking a deep dive into the data. So that's difficult as well. You have a valid question, and to Dr. Moore's question earlier about the NHTSA research, we do tend to publish in the fall. I'm sure there's some reason behind that. So you'll see some updated statistics in the fall. The final numbers, we've shown you the estimates today. But I mean, you have a valid question, and that's something we should discuss over the next 2 days. How do we get that changed in states so we know, well, one, so we know if it was drugs, alcohol, or both? And then also, to Dr. Moore's point, a lot of times if they're driving under the influence of alcohol, we don't know if it's multi-substance because it's too expensive to draw blood as well and then get that analyzed. And so it's a significant problem.
We have another question over here.
Yes.
My name is Paul Larkin. I'm with the Heritage Foundation. Is this field a subject where it would be appropriate, reasonable, or even desirable to have the federal government come together to not even necessarily require that states do it, but to establish what are the optimal guidelines with respect to testing? I mean, for example, would it make sense to have NHTSA in conjunction with CDC, NIDA, and other federal agencies come up with a best practices on testing? What should be done, when it should be done, what drugs should be the subject of the test, and the like, even if it didn't require the states to do that. It would be something that would be a good guide for states to be able to do. Could you address that issue?
Well, I don't work for NHTSA, this Christine does, so she could talk to that. But my feeling is, yes, of course, that would be very helpful, but the time that it takes to decide on which drugs and which cutoffs and which substance, and the time it goes through, now you've got a whole other different drug. We suddenly had fentanyl that nobody thought of 5 years ago, so then you'd have to keep adding things or taking things off, and that's a big, difficult, ongoing process. I think maybe cut it down is to do it for the 3 big classes: marijuana, coke, and meth, and not bother too much about the rest. If you want to do those, great, but at least start standardizing something. I think is a really good start, and we really should do that, because those are the ones that you find most often.
And if this is any reassuring statement I can make, is that the federal government, we do work closely. I can speak to NHTSA, we work closely with Federal Highways, with the ONDCP, CDC, on these very discussions. And born from those discussions was a project idea that NHTSA has taken on to create and develop regional toxicologist liaisons. And so we're hopeful that once that project gets implemented, some of these talks that we're discussing today, specifically to your question, are going to be addressed through those liaisons.
We have a question over here.
So going back to the 7% increase in traffic fatalities, I'm just curious if NHTSA or any other organizations has looked at the impact in terms of the number of law enforcement or the level of engagement of law enforcement, and to see if that is a contributing factor in not only traffic fatalities, but DUIs. No question that drug prevalence has increased, but often wonder if that, without the enforcement, if that's enabling those drivers or encouraging those drivers to drive and leading to some of this.
Yeah, as you might imagine, we've had a lot of internal discussions about that. Our anecdotal thoughts and discussions have led us to believe that, yes, in fact, one, law enforcement has decreased their traffic safety measures, and that's, due to COVID, due to the current climate in the country. There's a lot of factors that are going into that. As you might imagine, researching that and correlating the two is a little more difficult. But again, anecdotally, we are seeing through, and there was a survey done as well, and those results were published. I can't remember the entity that did it, but it said they surveyed a number of different law enforcement agencies who are in fact reducing their traffic safety, whether that's because of finances or lack of finances or because of COVID. And seems like common sense that is affecting the risky driving behaviors. I can tell you, when I drive on the street now, I can see a difference. People are speeding because they're not getting deterred. I mean, there's always a saturation point of deterrence, but really, again, anecdotally around the country, we are seeing less traffic enforcement, which could be leading to at least a portion of what you're seeing in those numbers.
Christine, I know we're almost out of time, but perhaps I can ask this question from our online audience.
Yes.
That we can consider as we move into the next session, which would be maybe a way to transition. Andrew Murray from MAD Canada asks, would it be a good starting point in serious crashes and fatalities if there's a required testing for both alcohol and drugs? And he asks pros and cons.
Do you want to start?
Well, pros, obviously, you get a lot more data and a lot more information about what substances and polysubstances people are driving while taking. Cons really is the expense. And maybe in some states you have additional charges if you have drugs as well as alcohol for the driver, but not all. And if you only have one, DUI situation because of alcohol, it's a financial thing, I think, not to bother to do the drugs. But the pros, Jennifer, help me out. You know the pros. Can you take the microphone to that lady right behind you? She's the expert on this.
I'm Jennifer Harmon. I'm a crime lab director in California. We actually did attempt to pass legislation in 2019 in the California legislature to require set testing for specific drugs in addition to alcohol, because we have 58 different counties who are making the decision almost entirely based on resources in those collisions where there are fatally injured. We were not successful in getting that passed, but I do think it's a very good start in terms of standardization. And we get out of the enforcement question when we're dealing with the fatally injured, where we're just looking at the potential causes of the crash, and one of those being people who are impaired.
Thank you.
I think we have one last question.
Hi, my name's Jane Terry. I'm with the National Safety Council. And I think just to respond a little bit about the standards, the document that you shared of the National Safety Council recommendations are being developed into consensus standards, that guidance document. So I know several agencies at DOT often adapt consensus standards from industry, and it's a little bit easier for those to be adjusted and changed as things change, as opposed to regulations. So there are some guidance that are out there and have been updated year over year by the National Safety Council Alcohol and Drug Impairment Division, of which Jennifer is a member, and others in this room. Also, I just wanted to ask, I mean, NTSB's done some awesome work around how do we end impaired driving, including drug and alcohol impaired driving. Has NHTSA ever thought about using the NTSB recommendations as a way to support the work that I know you want to do and be able to accomplish when talking to Congress and others of why you should be doing this work?
We do have those internal conversations, and that is another organization that has a voice at the table. A lot of those decisions are made well above my level, but we do consider that. That, along with some other recommendations from other organizations that you just mentioned, we take all of that into consideration. There are some factors that go into that, as you might imagine, but again, we don't rule out anything. We want to work with it's so important that all of the organizations and entities are working together because, for instance, in New Mexico, a DRE would do an evaluation on somebody, and the labs would base what they tested the blood for based on the DRE's opinion and the report.
Oh.
And so I know that
It's not so good.
well, they did an initial screening. Let me clarify, Dr. Moore. They did an initial screening. There was always, at the time, it was a 13 screen panel of drugs that they tested for. But if there was an additional drug like ecstasy or PCP, then those additional drugs were requested specifically by the DRE. So is that a little better?
Yeah, okay, a little better.
Just kind of speaks to how important it is that we're all working at this problem together.
Let's give a hand
we're
to
getting
Christine and
yanked.
Christine.
Christine squared. Thank you.